we lab. Yesterday what we have seen is what are various conditions in hypertension, and we were seeing pregnancy, and in pregnancy there are various conditions to what we call it as a eclampsia, gestational hypertension, then preeclampsia, and these are various conditions which are quite dangerous, which are the problematic one. Now in that then treatment we have to be very careful, because this topic again you will get it in therapeutics only. We call it as a drugs which can cross placental barrier, then they can have their effect on the fetus, and it can be deleterious one. There are many effects. If you have seen or if you are remembering, we call them as a teratogenicity, and many effects are there, mutagenicity, etc. So these all effects are problematic, and to avoid this we have to see that which are the best and the safest drugs are in that. So usually in case of this we have got various drugs which can be there. Here the drugs are for mild hypertension, whatsoever hypertension is there. The drug of choice in that cases are, the first choice is usually methyl dopa, then labetalol, that is a beta blocker, no other beta blocker. Then if they are not sufficient, then calcium channel blockers like nifedipine, that too not in capsulated form, and nicardipine. These both are good. No amlodipine. Then the drugs which are totally contraindicated, like RAS blocker, like AC inhibitors, angiotensin receptor blocker. Now word contraindicated, I think I have told you earlier, I repeat, contraindicated means which cannot be given, which should not be given at all. This is called as a contraindicated. Indicated means these are suggested, these should be taken, or these are the uses of the drug. So the drug which are indicated are these. Again, for severe hypertension, if it is more than that is systolic is more than 170 mm of Hg, in that cases again it is a intravenous injection of labetalol or nicardipine or esmolol, then hydralazine, urapidil. These are various drugs, or oral methyl dopa, or various calcium channel blocker. Again nifedipine, which is not in a capsular form, nicardipine can be given. And magnesium is beneficial. Magnesium can also help in prevention of eclampsia. Then during gestational hypertension, in last week particularly, or last few weeks of the pregnancy, so these are the drug which are there. In that cases suggestion is the delivery should be expedited, particularly if they are having women get problem because of the preeclampsia, and if the hypertension persists, the drugs like other drugs are there. Only methyl dopa should not be given, because it may contribute to postpartum, that is after delivery, postpartum depression we call. During breastfeeding, all antihypertension they are excreted into breast milk at low concentration, but atenolol, which is more lipid soluble, it should be avoided. Atenolol, propranolol, nifedipine, because they go for high concentration in milk. Long acting calcium channel blockers can be preferred, and again for each drug it has to be checked. Now there are various kind of hypertension emergencies. So whenever the hypertension is there which is not controlled, then it can cause the problems to various organs. We have called it as a HMOD, that is various organ damage is there, hypertension mediated organ damages are there, and these are the retina, brain, heart, large arteries, kidney, etc. And therefore it should be immediately diagnosed, and care should be there, because blood pressure, that high blood pressure can cause the progression into organ failure, and that can be very dangerous. Usually in that case we have to go for intravenous therapy, because we need immediate treatment, we need immediate action on that. So what are various types of these emergencies? What are we call? Example is malignant hypertension. Here see, malignant, although word is used in cancer, that is cancer is malignant. Here malignant means which is very severe, which is acute, and which is very rapidly increasing, that is called as a malignant hypertension. So it does not mean that it is associated with cancer. So this is a malignant hypertension. It causes severe elevation of blood pressure, commonly more than 200 of systolic and 120 of diastolic. It is associated with advanced bilateral retinopathy. It causes hemorrhages, it causes cottonwool spots, papilla edema. These are various kind of significantly observable changes it is having. Rather, best thing is measure the blood pressure. Then there can be hypertension encephalopathy because of that severe elevation of blood pressure that causes lethargy, seizures, then cortical blindness and coma in absence of other explanation. Hypertensive thrombotic microangiopathy, that is severe BP elevation that is associated with the hemolysis, and thrombocytopenia in absence of other causes, and improvement with the BP lowering therapy. So these are various conditions. A few more things are there, that whenever there is emergencies, there are various terms are used. One is called as a hypertensive emergency. So we have seen Ajit, I think it is for you or for everybody? Others are able to listen? They can hear properly? Okay, fine. So in that hypertensive emergencies, we have seen that where the hypertension is increasing, it is not controlled, and that is because of that whatsoever already damage has happened to heart, that damage has happened to whether various organs, may it be heart, may it be kidney, may it be brain, may it be other organs. So that go on increases, and then there are visible signs of the increase in the organ damage. So this is what we call as a hypertensive emergency. Then what is the difference with the malignant hypertension? Here malignant hypertension is, it is rapidly increasing, and it may or may not be resulting into only other organs are not involved, only retinopathy is there, and in retinopathy, hemorrhages, cottonwool spots and papilla edema, this type of symptoms can be seen because of the problems in the retina. So this is what malignant hypertension. There is one more term is there, that is called as a hypertensive crisis. Okay, these are different terms. Hypertensive crisis means hypertension is increasing. So far there is no big impact is seen on the various organs, HMOD what we have called it as a. So the hypertension mediated organ damage is not that much so far visible, but it is very sure that if it progresses or if it is not controlled, then it can lead to organ damage, and therefore hypertensive crisis is also an emergency. It is also an severe condition. So but these are three different terms: hypertensive crisis, hypertensive emergency, hypertensive or malignant hypertension. These are different terms, and these all are the terms are important to understand, and they need very immediate treatment. They need fast treatment. Then normally for that we need to go for various vasodilators, example nitrate like agents we can give, and other such which are very strong, example are diazoxide or maybe sodium nitroprusside. These agents they are preferred, they are put into, and simultaneously several drugs are preferred into that. So what are various treatments we shall see for hypertensive emergencies. So you can see the treatment: labetalol, nicardipine are the first line treatment, and sodium nitroprusside and urapidil are the second line or alternative treatment in all cases. This nitroprusside is one of the very, very important drug. Then acute coronary event, if it is there, then nitroglycerin is important one. In other cases we have seen that it is the labetalol and nicardipine. So labetalol, why labetalol, you must be able to answer it, because what is the mechanism of labetalol? Anybody? Or what is special with the labetalol? Vivek. Nobody. Fine, you just go through it again. In that cases, you can have it. You can go through. You will understand. If you remember, you can put it. I am observing. I am just reading the chat box. Now, other things are what are various conditions which we can have the secondary hypertension. Many times the hypertensive emergencies are there because of some other conditions also, like sympathetic hyperactivity, like amphetamine toxication or sympathomimetic agents, cocaine like agents. There are many agents are there which are causing sympathetic activity, or we have seen tyramine earlier. So these are agents which are there and they can cause it. So if it is there, then we can give nicardipine, nitroprusside, and some BP lowering treatment can be given. We have seen earlier pheochromocytoma. It is causing secondary, and it is causing release of adrenaline, noradrenaline from the adrenal medulla. It is a cancer of adrenal medulla, and therefore beta blocker use only after alpha blocker has been introduced to avoid acceleration of hypertension. Now, why this? Again, this has got pharmacological basis. Okay, if you use only beta blocker, then what will happen? The drug will able to bind only with the alpha receptor. So alpha 1 will be there, and then it will cause severe vasoconstriction, because agonist is available only for alpha receptor. So in that cases, beta receptor, why pheochromocytoma beta receptor not given in the beginning? Because until and until alpha receptors are blocked, it should not be given. Otherwise, this receptor will be blocked. So this is very important basics of pharmacology, and accordingly it has to be used. Then next are the various situations. Example is ethnicity, race, and hypertension. So various races or various people are having various sensitivity towards drugs. Example, if it is from African people, those which are black population, whether they are residing in Africa or United States or Caribbean or Europe, anywhere, and if they have hypertension associated with organ damage at younger ages, and they have a higher frequency of resistance and nighttime hypertension and higher risk of kidney diseases, stroke, etc. So for them, what treatment we can give? That is, they have problem again, suppressed renin-angio system is there, altered sodium handling is there, and increased cardiovascular reactivity is there. So in that cases, if we have to manage it, then here treatment should be thiazide diuretic plus CCBs plus ARBs lastly actually. And among these RAS inhibitor, ARB may be preferred, as angioedema is about 3 times more likely to occur in these people. If ACE inhibitors are used, then it can cause angioedema chances more comparatively to ARBs, and therefore it is there. Now ASIA means we people in India. Then what is happening here? These are, when compared to Western population, they are present at a high prevalence of stroke, that is paralysis and brain ischemia. So in that cases, what we have to do is we have to take further. Morning hypertension and nighttime hypertension are more common in Asia as compared to European one. Then in that, what treatment we should be taking? So these treatments are as per the guidelines. Go for it. Go for various agents like calcium channel blocker, because these are only the common guidelines. So you go for same guidelines, go for calcium channel blocker and ARBs, and accordingly we can have it. Now all this whatsoever we have studied so far, this is all a guideline for hypertension. Similarly, guidelines are available. Now in that you will there are many words you must be getting or you may encounter. I have not got answer so far. I have asked one question. So these answers are very very important. I told you earlier also what do you mean by the words like compliance. That means the patient should take tablet at given time in given way as per given directions. If it is thrice a day, means thrice a day. If it is not to be chewed, then it should not be chewed. It should not be broken, means it should not be broken. So this whatsoever sign symptom, whatsoever direction, whatsoever instructions are given to the patient, if it is following, we call it as a compliance. Those who do not follow, we call it as a non-compliance. Similarly, adherence is word is which is very popularly called adherence is means completing the treatment. If it is asked for taking tablet at whatsoever given time is one thing, timely taking is one thing, and secondly timely and taking it for a given duration. Suppose it has been told that being a hypertensive patient you have to take it all the times permanently till next checking or the follow-up studies shows that now your hypertension is in control, then only clinician can stop it. However, many times people may stop at their own, and then it can be very dangerous one. So this type of thing is called as a non-adherence, that not sticking to the treatment or losing the treatment. So these are various conditions which are associated with various situations. Now let us go for a very short this one what we can say very short and good presentation which will help you to understand or make it in short way. So just I'll give for another one. Just a minute. So this is the what algorithm is. Again this is for adult. We have seen this much. What are the BP goals? That is, we have to decide that at what level. If it is very high, then at what level you have to make it, at what level you have to bring that. That is called as a what are the goals of your this one. We have seen various goals in last lecture. That is bringing down by 10 or 20 mm of Hg, or bringing towards normal, or particularly whatsoever prescribed range is given for that particularly group of people, then we have to reach towards that is what our goals are. And the important goal we have seen, the most important goal is reduction in the mortality and morbidity. This is also we have seen earlier. So we are trying our best that the patient, because we know that if the hypertension is persisting, then patient will have problem with various organs, and because of any of this problem, whether it may be brain, heart, kidneys, because of any of the problem, the patient may suffer or may even die. So our main aim is to reduce the mortality. Now what are the situations we have, and accordingly what we are going for. So adult which are more than 18 years having hypertension, so what we'll do is we have seen earlier lifestyle modification. We have seen so many lifestyle modification situations: diet condition, reduction in alcohol, reduction in nicotine, exercise, many things we have seen. So these are all, we call it as a lifestyle modification. Then we have to set the BP goal. Whatsoever BP goal is there, then we have to say that within 3 months we have to normalize it towards 10 less or 20 less, like that. So this is how we are making our goal. Okay, with treatment where we have to control, at what level we have to present. Then what kind of population we have, that we have to check whether it is a general population without any kind of diabetes or kidney disease, or whether it is having either diabetes or chronic kidney disease. So if it is there, then our treatment goal will be changing. Now in all cases, in this, suppose the age is more than 60 years or age is less than 60 years, our BP goal, in case of age is more than 60 years, then our BP goal is 150/90. While if it is less than 60 years, then our BP goal is less. It should be, our blood pressure should be controlled or should be kept in the range of 140 or 130 to 140/90. Now again, what kind of people we have got, black or non-black, in both cases. So this will help us to understand what kind of people they have. Here, if it is diabetes and or kidney disease, then blood pressure is there. Whatsoever age the person is having, our BP goal should be make it to less than 140/90, because the diabetes and kidney diseases, they have their own other complications which are putting into. Then next is all the ages and races where CKD is present with or without diabetes. Again, in this also we are going to make our goal of 140/90. Now what we will do in that cases, when we have CKD with or without, then our first initial choice will be AC inhibitor or ARBs, either alone or combination with any other class. Now here, if it is the case, in this case, what we will be doing, we'll start with the thiazide. As I told you, thiazide is the first line treatment. Then if required, then go for either AC inhibitor or ARBs or CCBs, either alone in a combination. These are the treatment. Usually number 1 is thiazide, number 2 is AC inhibitor, number 3 is ARB, CCBs. But any of these can be started by the clinician. Here in case of the black, it should be either thiazide or CCBs, because we have seen that they are having reactions to, just now we have seen in earlier guideline that they have reaction towards these AC inhibitors. Then whether blood pressure goal has met, yes. If yes, then continue this treatment and continue monitor. Okay. If it is there, then continue the treatment and continue the monitoring. So your goal has been met. Patient is okay, patient is safe, give him time to come at various time. If it has not met, then what you will do is, you will again check then whether the patient is following the guidelines about lifestyle is or not. We have seen what are the lifestyle suggestion. These are smoking cessation, blood glucose control and lipid control, then diet, healthy diet like DASH diet, decrease in the alcohol consumption, reduction in the sodium diet, increase in the physical activity. These all are various lifestyle changes. So these changes, if whether these are done properly or not, and if not, then see that how you can improve this. If you feel that it was adequate, then still more what you can do is, suppose you ask for reduction in the alcohol but it is not sufficient, or the patient thinks that okay, moderate alcohol likha hai, so I'll go for moderate one, but then you may feel that you can stop it or you can totally control it like that. Reduce sodium intake, again it may be depend on people to people. That is, if it is it should be less than 2400 milligram per day, and still more if possible can be done. So like that, so many lifestyle changes can be done. Then if it is not there, then check it. If it is there, yes, then continue treatment. Again, no. Despite of that, if it is not there, after all verification you found that goal has not met, then go for that. Again, yes, Saba, good question. It is not human colors, beta. It is what the we call it as a genetic and racial variations. So because of that, these people are having various kind of genetic makeup, and the slight variation in this genetic makeup, we call them as a racial differences. That various races, they have various differences, maybe because of changes in the secretion of hormones, changes in the structural or functional whatsoever groups which are present. So these may be receptor, this may be secretion of various enzymes, these may be secretions of various chemicals, these may be various metabolic pathways. Because of any reasons, there are many reasons behind it, and because of that, few races are having more activity towards few drugs and few are having lesser activity. So this can happen. So we call it as a racial variation or genetic changes which are there because of the genetic inheritance that particular races are there. Okay, so this is now still you are not reached to the blood pressure goal. Then what next? So reinforce the adherence and see that adherence, and add the medications whatsoever you want. It can be addition, that is, it may be you can add any beta blocker, you can add aldosterone antagonist, example that is spironolactone, and you can titrate. Now here titrate means not analysis titrate. Here many times you will get word in therapeutics, that means we call it a titration. Titration means we are adjusting the dose, that is dose titration. Dose titration means it is not analysis like ब्यूरेट पिपेट में लिया और ब्यूरेट से डाला उसको टाइट्रेशन बोला. इट्स नॉट लाइक दैट. हियर टाइट्रेट मीन्स व्हाट, दैट यू आर चेंजिंग द डोज, कम ज़्यादा करके उसको रीचिंग टू द एक्यूरेट डोसिंग. बिकॉज मेनी टाइम यू विल फाइंड, अगर फार्मेकोलॉजी में तुमने देखा होगा कि डोज इज़ अ रेंज, मिनिमम इतना 20 मिलीग्राम से लेके 40 मिलीग्राम. अगर 20 से 40 है तो फिर इसको 20 देना है, 30 देना है, 40 देना है. दिस इज़ व्हाट वी कॉल एज अ टाइट्रेशन. Okay, how you titrate? You give the start the treatment, see the effect, you feel that it is not sufficient enough, then give for that. Or if you go for higher one and you feel that the patient is not able to tolerate it, if there is any adverse effect, then there is no use of it. So in that cases you have to titrate it so that it can be safer one and effective one. Then next in that is whatsoever treatment is there, check. Now I think it should get clear, but if it is not there, then continue the treatment if it is made. If your goal was there, you have already said that this was my goal, that is BP goal should be either 140/90, 150/90. If it is achieved, fine. If it is not achieved, then again go for checking everything, go for checking lifestyle, make it, ask them to follow it very strictly, try to check the adherence, whether the patient is taking medication timely or not. Then titrate the medications to the maximum dose, because we have titrated earlier, maybe not it was maximum dose. Or you can add another medication and or refer to the hypertension specialist that now the patient is not correct or it not responding. Okay, so these are various things. Now again in this we have seen, while this we have got various strategies. Now what strategy we can have? It can be strategy A. Strategy A means what? Only one drug we are starting, and if it is not showing response, suppose it is calcium, it is let it be suppose calcium channel blocker, and its minimum dose is 5 milligram, maximum dose is 20 milligram per day. Then you started with 5 milligram, you check, observe, check your goal was there, goal is not meeting, then go for 10 milligram. If still it is not there, go for 15 milligram. Now you are going towards a maximum dose. Okay, so this is what we call it as a titration. We have started with one drug and we are titrating towards the maximum dose, but we are keeping only one drug, we are not going for any other drug. Now second is what, you start with one drug, but if you feel that it is not a sufficient one, then add a second drug. But before achieving the maximum dose of first, means you are not going towards the maximization of dose. In last one we have seen that if the maximum dose is 20 milligram, then you are going for 15 milligram or towards the 20 milligram. That means the maximum dose. This is how you are titrating. 5, no response, 10, response is not enough, 15 still you want, there should be improvement, go for 20. This is how you are titrating the dose of A and a single drug. In B, what you are doing is you have started one drug 5 milligram, then you feel that no, it is not sufficient, you are not able to meet the expectation, the goal is not achieved, blood pressure is not coming in control, then go for 10 milligram. Now 10 milligram is somewhere medial dose. Okay, 5 was minimum dose, 10 is slightly higher than the minimum dose, and 15 is almost closer to the maximum dose. Now what we are going here is, when we reach to 10, then we add another drug. So before it achieving maximum dose of the first, we are going. In C, we start 2 drugs at the same time as a separate pill or combination pill, and this initial therapy of combination is recommended if the blood pressure is greater than 20 or 20 to 10 mm, that is 20 systolic and 10 diastolic is above, then it is suggested. So this is how various drugs are there. Let us see what are the initial drug or the first line treatment: AC inhibitors, thiazide derivative, ARBs, and calcium channel. These are the first line treatment. You have studied so many drugs in hypertension in pharmacology. Here we are concentrating only on 4. Only here what we are doing is, what is difference in therapeutics and oncology now? In oncology you studied drugs, here you are studying disease, and then what treatment will be better in that particular treatment, for the treatment of that particular disease. Now what are various treatment which are available for us? Example, simultaneously there is any kind of comorbid situation. So what it can be? Example, it can be heart failure, it can be after myocardial infarction, or coronary artery disease is there. It can be coronary artery disease, it can be diabetes, it can be renal disease, it can be stroke, it can be pregnancy. So these are the situations which are there, comorbidities or situations are there. Now what treatment you will go? If it is a heart failure, then what will be your choice? The first choice will be AC inhibitor and ARBs. Then beta blockers, diuretics, spironolactone. Then if it is myocardial infarction, or there was a clinical coronary artery disease, clinical means the patient was admitted and it was severe one, then go for this AC, that is AC inhibitor or ARB and beta blockers. If there was a coronary artery disease like angina, then AC inhibitor, beta blocker, diuretics, CCBs can be given. If it is diabetes, you will see that beta blockers we are not using, we are using ACE, ARBs, CCBs and diuretics only. If it is chronic kidney disease, then we are preferring only ACE, ARBs. If there is a stroke prevention, instead of ARBs we are preferring no other drug except AC inhibitor and diuretic. This is our preferences. In pregnancy, I have just now told you, labetalol is the first line, then nifedipine and methyl-dopa. These 3 are most important. Again, nifedipine not in capsule form, if you remember just now we have seen it, or nicardipine we can use. Okay, these are various activities. Now if suppose the patient has got bronchial asthma, we know we are using in respiratory system, in pharmacology we have seen, if the patient is having bronchial asthma, then our problem is, if we use beta blocker, then the problem is they may cause, because although they are selectively beta blocker or beta 1 blocker, they may show effect on beta 2 receptor and can either contribute or can exacerbate or can affect the asthma. But those which are comparatively safer in the COPD, asthma, diabetes and peripheral vascular disease, these are metoprolol, bisoprolol, betaxolol and acylbutalol. They can be given in these conditions when there are asthmas. Now we can have a summary of various hypertensive agents which can be used and what can be the impact of each. Now let us see one by one. Diuretics, thiazide or chlorthalidone or indapamide, these are 3 thiazides, their dose are given. Then the other diuretics which are there, they are, example of these is spironolactone, we call it as a potassium sparing amiloride, and triamterene. These are the agents, these are the doses also. We have, you can see the dose. The another diuretic class is there, that is called as a loop diuretics or high ceiling diuretics. They are having very high potency. They increase urine production by around 40-60% and very powerful. These are furosemide and torsemide. They are the drugs. Now, what we should do if this treatment is prescribed, then monitor for hypokalemia, because they are causing loss of potassium, and potassium ion balance is very, very important into it. Then most these serious adverse events are there, or serious events or adverse effects we call them. They are metabolic in nature, most effective when they are combined along with the ACE inhibitors. Then their effect is increasing, diuretics. Stronger clinical evidence, particularly with the chlorthalidone, that it has found to be very effective, very useful. Spironolactone gynecomastia is adverse effect, and hyperkalemia it can cause. And loop diuretics may be needed when glomerular filtration rate is reduced below 40 milli, that is in case of kidney failures. So in that cases, this loop diuretics, the last one, that is furosemide and torsemide, can be used. Then next are the ACV ARBs. There are ACE inhibitors, there are many in that, like lisinopril, benzapril, fosinopril, quinapril, and old ramipril, old trandolapril, older one enalapril, etc. There are many prils, as I told you. And ARVs are there, that is candesartan, valsartan, losartan, olmesartan, telmisartan. So many sartans are there. So ACE inhibitor has got a adverse effect of cough. Only ACE inhibitor causes, ARBs are not causing. And losartan can lower the uric acid level. Candesartan may prevent migraine headaches also. Additional benefit it is offering, and comparatively they are safer, comparatively they are better. Then next one are the beta blocker, metoprolol succinate and metoprolol tartarate are the main agents. Nebivolol, if you go for again beta blocker, you will find this is a nitric oxide releasing agent. Propranolol, carvedilol, bisoprolol, labetalol, these are various drugs, but they are not first line agent. They are reserved for post MI or CHF, that is cardiac failure, congestive cardiac failure. They can cause fatigue, they can cause decrease in the heart rate, and they can adversely affect glucose, and they may mask hypoglycemic awareness. So body may not sense the hypoglycemia and can be dangerous into this. Then next are calcium channel blocker. Example of these are various agents. Most prominent in hypertension are dihydropyrimidines, amlodipine, nifedipine, then diltiazem, verapamil, but they are not used. They are having little uses because they are having more effect on heart, and therefore we do not use it. They can cause edema, and they can be safely combined with the beta blocker. Vasodilators like hydralazine or minoxidil, they can be used. Hydralazine and minoxidil may cause reflex tachycardia and fluid retention, and usually they require diuretic and beta blocker along with it. Then alpha 1 blocker, that is terazosin, doxazosin, these are the alpha 1 receptor blockers, and they may cause orthostatic hypotension. If the patient stands up from sleeping position or supine position, then can have severe problem in this patient, because these are most prominent in that. Clonidine is given, or methyl dopa, they are given in weekly patch formulation for resistance hypertension. Resistant hypertension means which is not given any kind of positive response to the normal routine treatment. So this is how hypertension is treated, how these guidelines and these various